My name is Farhad Ravandi. I'm professor of medicine in the Department of Leukemia at the University of Texas MD Anderson Cancer Center. I am going to talk about XmAb 14045, which is a bispecific antibody targeting CD3 on the surface of T cells and CD123 on the surface of leukemic blasts. The antibody is an immunoglobulin-like structure which gives it a longer half-life, allowing it to be administered by short intravenous infusions. There has been interest in developing bispecific antibodies in AML because of the success of blinatumomab in acute lymphoblastic leukemia, and a number of bispecific antibodies are in development. The attraction of this agent is its administration by short intravenous infusions, as a number of other bispecific antibodies are available that are have to be given by continuous infusion intravenously. This agent was evaluated in this phase 1 study in patients with relapsed and refractory AML, and over 110 patients were enrolled. The study showed that this agent is active and can produce responses. However, the patients most likely to respond to this agent were those with lower disease burden, with less than 25% blasts in the peripheral blood or bone marrow. This suggests that there is significant activity of this agent, but perhaps as one could think in terms of conceptually, this agent that works on recruiting immune system would probably be best in a low disease burden setting, such as in the measurable residual disease setting, or in patients with myelodysplastic syndrome. And this is where the sponsor is going to consider future studies of this agent. The full dose and regimen strategy is still being evaluated in the continuing phase 1 study. The side effect of the drug is, like all bispecific antibodies, is cytokine release syndrome, and this can be mitigated by a lower dose, initial dose, and a step-up dosing strategy, as well as by use of pre-medication with steroids and judicious use of tocilizumab in the first signs of cytokine release syndrome.